Prolapse and incontinence are very common problems affecting women. Many women feel embarrassed to talk about them, and therefore the true extent of that problem is under-recognised. So on today's podcast, I'd like to talk about both of those things, and we'll start with prolapse. That, for you, might present itself as a sensation of something coming down. It's variable in its extent, and it's much better managed proactively. So talking about this now is really important because it will allow you to deal with the potential problem before it becomes a major issue. So let's just go back to basics here. Our pelvic floor is made up of a mesh of muscle and fibrous tissue, and how well that functions to a certain extent is something that you inherit genetically. However, if you think about it, we were probably never really meant to stand on two legs because our pelvic floor is challenged from the outset. And that challenge becomes a bigger issue depending on your weight, your body mass index. So if you are overweight, the pressure bearing down on your pelvic floor will be greater, and almost inevitably you will be more at risk of developing a prolapse. There are things which increase your likelihood of developing prolapse, and number one is probably having children. So even a normal delivery will have an impact on your pelvic floor, but having a prolonged second stage of labour, having instrumental deliveries, so forceps or Von-2s, having an episiotomy, all of these things can add to the likelihood of you having a problem. And when you think about an episiotomy, that's a scar which will be made up of fibrous tissue, and fibrous tissue is less able to stretch in response to a stress. It's much more likely to tear or to weaken, and that will increase your risk of developing a prolapse. So there are some other things which will increase your risk, and I like to think of this as the 3 C's. So we've had children, we've got coughing, and being a smoker will increase the risk of coughing and therefore increase your risk of prolapse, and constipation. So if you're at home now thinking, I've had a sensation of something coming down, I've had 3 children, difficult labours, I'm a smoker. Well, now's the time to go and see your doctor, and also look out for our next podcast by specialist pelvic floor physiotherapist Katie Mann, who's going to talk to you about what you can do to look after your own pelvic floor. Prolapse is more likely to be an issue post-menopause, and part of the problem there, as we've spoken about on many of the previous podcasts, is lack of estrogen and the effect that that has on the pelvic floor. Pelvic floor exercises should be done from as soon as you possibly can, ideally pre-childbirth, but certainly from childbirth until you can no longer stand up, because they're really important. They can improve urinary continence, reduce the risk of prolapse, and if you have neither of these things, then your quality of life and your well-being will be massively improved. I don't think many women do pelvic floor exercises apart from maybe for the couple of weeks after they've had a baby. So if you take nothing else from this podcast, take the message that you need to do pelvic floor exercises lifelong. There are loads and loads of apps out there to help you understand what you should do and to remind you to do them, because that's always a major issue. Life's busy. However, you can do your pelvic floor exercises while you're making dinner, while you're ironing shirts, while you're stuck in a traffic queue. So there are really no excuses. If you feel that you might require the addition of estrogen to improve the tissue quality in the urogenital region, then see your GP. As we've said before, this can be delivered as a little pessary, as a cream, as a gel, or as an impregnated ring. So there are lots of different ways of delivering local estrogen, and you want to find the way that suits you best, the way that appeals to you most. Okay, moving forward, if you feel that you have a prolapse that isn't responding to any of the things that we've talked about already, then there is the option of using pessaries. And pessaries are not just rings, there are a whole range of different forms of pessaries. And it may be better for you to see a specialist, a urogynecologist, who can recommend the best type of pessary for you. Some GPs are also have also developed expertise in this field, and they may be able to advise you, as may a nurse, a practice nurse who's done some additional training. So don't think because you have a prolapse that you have to have an operation. And just remember that if you do have an operation, then any of the healing tissue will have an excessive amount of fibrous tissue, of scar tissue, and that in itself will increase your risk of having a further operation. So avoiding surgery is definitely the way to go, in my opinion. And also, we are still in the midst of a huge amount of controversy about meshes that have been used as a part of surgical repair for conditions such as urogynecological prolapse. So incontinence can take the form of stress incontinence. You don't even have to have children to get stress incontinence, and that's when we leak a little bit. If we laugh or sneeze or run or jump, even men can get stress incontinence. That results from an increase in intra-abdominal pressure. So when you sneeze, there's an increase in the pressure in your abdomen. And in an ideal world, that will put pressure on the urethra as well and avoid leaking. But if the valve between the bladder and the urethra has dropped a little bit, then obviously there's more of a risk of leaking. Urgency often occurs in the menopause transition or postmenopausally. Many women, if they're planning a shopping day out, will also plan where all the toilets are so that they don't have an accident, because they may not get the same warning that they got before. They may have that key in the lock thing where they know they need the toilet, but as soon as they put the key in the lock, they start to leak rather than being able to hold on until they reach the toilet. And that's part of something called overactive bladder syndrome. It responds very well to medication. Many types of incontinence are mixed, so there may be an element of stress, an element of urgency, and if the balance falls in favour of urge urinary incontinence, then medication will still have a beneficial effect. But there are no good medications to treat stress urinary incontinence, and therefore we look at other options. And there are various things which can be used, including Botox or a kind of filler for the bladder. But all of that would be based on the findings of a urodynamic assessment. And if that's required, then really you would be better referred to a specialist urogynecologist. Sometimes incontinence is unprovoked. It may be confused with vaginal discharge, and it may be, depending on your medical history, that you've developed a fistula. That's a little passage between the bladder and the vagina, or the back passage in the vagina, and that can result in constant leaking of either urine or feces. So if we are thinking about how to manage incontinence and prolapse, I think it's important that whoever sees you will take a detailed history, that you would expect to be examined because you may have huge fibroids that are pressing on your bladder, resulting in incontinence. It would be normal to do a urinalysis to check for urinary tract infection. It's normal to ask the patient to record a bladder diary, and a bladder scan can also be very useful, because if you have passed urine but there's still urine left in your bladder, that would be suggestive of incomplete bladder emptying. So I hope that's given you the confidence to seek assistance from primary care, from your doctor, your GP, your practice nurse, your practice pharmacist, if you are suffering from either prolapse or incontinence or both. And I hope you will listen out for our expert pelvic floor physiotherapist who is going to do a podcast both for health professionals and also for patients.